Hey, everybody. This is Chris.
And Kathy.
We wanted to take a minute to thank you all for tuning in. We appreciate every listener and are grateful for this platform.
Please help us share our vision by subscribing to our show through your favorite streaming app. Follow us on Facebook, Instagram, TikTok, and YouTube at Petability Podcast.
Check out our ever-growing list of affiliates and sponsors. Simply go to the show notes for information and links. Proceeds from purchases help to support our show. Thanks for listening.
We hope you enjoy the show. Welcome to Petability. I'm your host, Kathy Simon, certified veterinary technician and certified canine rehabilitation practitioner.
And I'm your host, Chris Cranston, licensed physical therapist and small animal physical rehabilitationist.
Our podcast provides interviews and information to help your pets live their best lives. Hey, Chris, how are you doing this afternoon?
I am very well this afternoon, despite the rain outside. I've already gone for a little walk and I'm ready to do this.
Oh, I know. We have such a great topic today. I can't wait to introduce you to my friend, Dr. Keenan. But before we get started, Chris, I wanted to share something with you because I've been following something online that's really cool. And I wanted to highlight this sort of remarkable feline hero. This woman's name is Kay Ford. And you may have heard of her. She's been all over the news and social media with her cat Patches. Patches had been taken in and being cared for by the Richmond Animal Care and Control Center in Virginia. And he was looking for a home, and they had him on the news. And this cat weighed in at a staggering 42 pounds.
Wow. And this is just a normal, like, domestic short hair, right? Not some giant breed cat. Okay.
No. And Miss Ford saw this cat, this now famously circulated photo in the news, and she stepped up to adopt this boy and started him on his weight loss journey. And, they've inspired a bunch of people to get up and start moving because they have a huge following. And it's so cute. Patches and his mom, they walk every day because they're both on a weight loss journey together. And people are following them and they're getting up and moving. And I'm proud to say that the most recent report is that Patches is down to 38.8 pounds. So they still got, some work to do, but it's coming off. So kudos to Kay Ford, kudos to Patches and the staff at Richmond Animal Care and Control. I appreciate that they took this cat's obesity seriously because pet obesity is no pun intended, but it's a growing problem in the United States. And we did a show not that long about it when we discussed the implications of pet obesity and its potential to lead to life-threatening diseases. So if you haven't listened to that show, go back and check it out. So thank you, Kay Ford. You're a feline hero.
Yeah. And I'm glad you mentioned it, that, the fact that it's a cat too, because I think a lot of people just throw up their hands and say, well, my cat just loves to eat and there's nothing I can do. Well, there are things you can do. So
right, there are. And this guy's on his way. I look forward to updates for Patches.
Awesome.
So anyway, on to our show. Mm-hmm. I am really happy to introduce to you my friend, Dr. Kathy Keenan, today. She's amazing. And I always find it a little difficult to express my feelings when we interview someone who's a close friend or in your close circle, and how truly important this person is in your life. And we've known each other for probably 35 years. And she's been a mentor, a friend, and a constant source of comfort for me in difficult times. And on top of that, she's an amazing veterinarian and a fantastic teacher. So before we get started, let me give you a little bit of background on my friend, Dr. Keenan. Dr. Keenan is a graduate of Ross University and has been practicing veterinary medicine for 21 years with a focus on emergency medicine and critical care. Dr. Keenan is a highly experienced and accomplished veterinarian, and throughout her career, she has worked in a variety of settings, including private practice and emergency care centers. She also served as a clinical instructor at North Carolina State University. Dr. Keenan has a passion for animal health and welfare, and it's evident in everything that she does, and her expertise and dedication have made her a respected and valued member of the veterinary community. However, her life privately is completely dominated by her two dogs, Rosie and Calypso. So today, Dr. Keenan is going to talk to us today about renal replacement therapy, what it is, How is renal replacement therapy performed? And what are the main indications for using this type of treatment for pets? So please welcome to the show my friend, Dr. Kathy Keenan.
Welcome, Dr. Keenan.
Thanks, guys. Thank you for having me. I'm excited to talk about this. It's a topic that I'm really passionate about and very, very excited about.
So let's dive right in, Dr. Keenan. Why don't you tell us what renal replacement therapy is? Is it similar to dialysis, or do they differ?
Yeah, so dialysis is part of it. Quite literally, a number of different therapies that we can do for the body that's done outside of the body. So we take blood out of the body, run it through a big machine, and put it back in the body. We treat it in the machine. And so when we're doing something like dialysis, when you think of that, you think of, for people going to those big dialysis centers who are being treated for kidney failure. And we can do those kind of things in dogs and cats. We don't do it quite to the extent that they do it in people, because we're not a cat or dog that has end-stage kidney disease. We're not at a place in veterinary medicine quite yet where we can do like a renal transplant, a kidney transplant. So we feel that it's maybe not always in the best interest of the patient to be doing dialysis when they're at the end of those diseases. But if they have acute injuries, we can treat them to give the kidney a chance to heal. We can also use it to do things like treating a lot of different other diseases. There's a lot of diseases of the immune system where your immune system attacks your body. It makes you very, very sick. And it happens in dogs and cats as well. And so we can treat them. We remove, by running their blood through our machine, we remove those immune products, give the blood back to the pet, and it helps them to feel better until the medications that they're given start to kick in. Another really useful tool, especially in veterinary medicine, is toxicities, because as we know, especially our dogs, cats are usually less likely to do it, but they'll do it, is they'll eat things that they shouldn't eat. They get into your medications, they get into the other pet's medications, they pick up something on the street. And if they ingest something that's really seriously toxic enough, something like ethylene glycol, antifreeze, very, very toxic, or they ingest such a large amount that it's going to cause serious damage to their body, we can actually treat them and take that product out and stop that serious complication from happening.
It almost sounds like we're mimicking what a healthy kidney might be able to do. Is that a reasonable statement?
For the most part, yep. Everything we do isn't necessarily what the kidney does. We can actually now do things like what we call liver dialysis. So we're mimicking what the liver does, but all in that same machine. But a lot of times, in the early days when they were first working on dialysis and it was first being discovered, it was actually called the replacement kidney. But now we do other stuff that it's not necessarily done in the kidney, but it treats the blood. But for the most part, it's you're kind of taking over the work of the kidney. So it doesn't fix the kidney and like things like kidney failure. It just takes over the function of the kidney so the pet can feel better and the kidney has time to heal.
So Dr. Keenan, you mentioned a couple of times, when referring to our pet friends, dogs and cats. Are these two species the only two that renal replacement therapy is currently used on in veterinary medicine?
No, we can use it on anything. The interesting thing about veterinary medicine is that there's all these things that are done in human medicine that we actually can be done in veterinary medicine, but sometimes we're limited because some of our patients are so big. And so, for instance, if we could do dialysis on a horse, and people do in universities and things, but the equipment we have is usually all the same equipment that's made for people. And so it's a little too small. So we have to either use two machines or kind of set up more filters and stuff, because a horse has way more blood than a person. But we can do it to almost anything that needs blood treated.
You mentioned like running through a machine, and we'll probably get to, more of the details later, but how does this machine determine what is actually filtered out? How does it know what the bad stuff is and what to allow through?
Oh, so that's the thing that I like the most about it, because it's just fascinating, because there is so much stuff that we can do. And so it depends on what we're trying to treat. So for instance, if we were trying to treat, say, a real common one that we see is the dog ate the giant bottle of ibuprofen that the person bought at Costco, the 500 tablet bottle. And now it's had a huge overdose of ibuprofen. It's going to make it really sick. Probably it would die if we couldn't treat it. And so in a case like that, we know that that drug binds very tightly to proteins in the blood. And what we do is we do what's called plasma exchange. And with plasma exchange, we have these special filters. The blood is taken out of the patient, and it's separated. The cells, the red blood cells and white blood cells, are separated from the water part that has the protein. And we take all of that water section out and replace it with new protein. And so we can specifically do that, remove as much of that ibuprofen as possible, and help that patient recover. But with things like if we're treating kidney disease and we're trying to adjust, maybe their potassium is too high, or some of their kidney values, their BUN or their creatinine are too high, the way that it works is there's dialysis fluid that we use, and it has a lower concentration of, say, potassium than is in the blood. And they pass each other in this filter. The blood goes on one side, the dialysate goes on the other, and the potassium will move across the filter from the higher concentration to the lower concentration. So therefore it gets taken out of the blood.
Would that be like osmosis?
Yeah, that's exactly what it is. Yeah.
Yay, my biology days have served me well.
Good job, Chris. Good job. About cancer patients, are we looking at treating some of our patients with, say, lymphoma with renal replacement therapy?
Yeah, so it's not so much the renal replacement therapy, but what we do is we do these, they're called centrifugal therapies. And so what we do is we pull out the blood, and then you run it through a centrifuge, and it collects all the blood down, and all the different cells will layer out at different levels depending on their how much they weigh. And then we can say, well, the patient with lymphoma has too many lymphocytes, which is a type of white blood cell. And we tell the machine we want to get out some of these lymphocytes, and the machine will know to reach down into a certain level, take the lymphocytes out, and take a bunch of those lymphocytes out, and then we can give them back the rest of the blood. And then we can also choose to treat cancers by arming certain types of white blood cells. So again, we take the cells, we use the centrifuge, we get a certain type of white blood cell, say like a lymphocyte, goes to a lab, and they arm it with certain things so that it will attack cancer cells, and then you give it back to the patient. And so it's a natural way of killing some cancers without using all the toxic products of chemotherapy. And so those therapies are growing more and more, and we're starting to use them in veterinary medicine as well. And they're fascinating to talk to these people on how they do it. Of course, the thing that becomes complicated is then the cancer cell learns what's being attacked and they change, but then we figure that out and we change it differently, and we can exchange those things out.
Very, very complex. I mean, bottom line is it's not a one size fits all. It's very specific to what is being treated, the condition or the ingestion or whatever it may be. That's crazy.
But think about the possibility too, Chris, like if you were able to do this versus, going in weekly and having, your dog have their chemotherapy session, and then some of the dogs have to be sedated or radiation therapy. If this was an option for treatment, that would be fantastic.
Absolutely.
Yeah, it's growing more and more in veterinary medicine that these things are happening. And so they're a natural thing too, and so that they stay in the body. And so those RN cells will reproduce in the body. So for patients that have relapses, they've got cells that can help fight that.
So is the use of this machine, renal replacement therapy, is this something that started in human medicine and is now being extrapolated to veterinary medicine, or vice versa? Was it originally studied in veterinary medicine and then people used it, but it was too, maybe cost prohibitive to use for our animals? Where does the background lie there?
Yeah, it started in human medicine, way back in like the 1800s. They were looking at this, the 1700s. They've been looking at this. And then it became more and more common. And then like in the 50s and 60s, they started using it more commonly in people. And then it was actually kind of around the 70s in veterinary medicine when they started trying to apply it to veterinary medicine and try to figure out how all of this would work. And, I think one of the biggest roadblocks that we had in veterinary medicine was just that a lot of our patients are much smaller than people. And because one of the things that makes it complicated is that we are treating your blood, and we literally take the blood out of the body, like all of the blood out of, not all at once, but we run the blood out of the body through the machine and back into the body. And when we're doing that, there's this there's the filter and then all of the other like IV lines and things. And you have to calculate how much blood is going to be outside of the body. So one of the things we had to be able to come up with filters and sets that were small enough that we didn't take all of the blood out of the patient. There was enough blood in the patient to keep them alive. And so that was a big thing, to be able to get smaller things created. And that's mostly just working with companies and then learning more and more what we could do with it with veterinary medicine. And now there are companies that are focused on the veterinary side of it. So making smaller filters and actually making stuff that much more applies to veterinary medicine, just our patient's smaller size.
Sounds like it might require possibly a little sedation on the animal's end. Like, what do you do to prep the patient for this treatment?
Yeah, it's usually just some sedation. So probably the biggest part is when they first come in and we have to place the dialysis catheter. The dialysis catheter is a really big catheter that we put in the jugular vein. So that's a big vein that's in their neck. And it goes down, and sometimes it actually goes all the way down into the heart, or in like a really big dog, it's just outside of the heart, because we want to be able to process large volumes of blood quickly. So we need something really big that we can draw all the blood out. So for placing that dialysis catheter, they are very heavily sedated for that part. So they'll lay still and let us do that. And if it's a patient that needs maybe just a treatment because they ate a toxin, that they just get a dialysis catheter. But if it's a patient that, say has kidney disease and it's going to be treated for a long time, coming back and forth for treatments, a lot of those patients aren't eating very well either. So when they first come in, we place a dialysis catheter and a feeding tube at the same time so we can make sure their nutritional needs are met. And then when they actually have their treatments, they're usually just under sedation. The dialysis centers and hospitals are off to the side in a very quiet place so we can keep them nice and quiet. A lot of times they'll just lay on the table. Cats, a lot of times will just, if you build them a little place to kind of hide, they'll just lay in there. Sometimes you can play with them a little and sometimes try to feed them and do things like that for them. But usually it's just sedation.
So they can be in any position that they would like, as long as they're not moving too much. They can just be in a position of comfort.
Yeah, we usually want their head extended a bit. Like if they're going to turn their head, it might kink the catheter if they turn toward the side where the catheter is. But otherwise, yeah, they can just lay there.
Yeah, because I think it's important for pet owners that are potentially, considering this or have the opportunity to use this technology to feel that their pets aren't being, extremely manipulated or having to be in an awkward position for an extended period of time. So this is reassuring.
Yeah, that's really important for people to understand that. And, there's patients that will be treated long-term that have, usually patients with severe kidney disease, that we have an expectation they're going to get better. And like dogs, they'll get used to it and they'll come in and they'll just jump up on the table, and they're just like, okay, I'm ready.
That's always a good sign, right?
Yeah. They're fun. They're like, okay, here we go.
Okay, let's do it. Yeah. How many veterinary practices in the country do you think are doing renal replacement therapy?
Yeah, there's not a lot. I think off the top of my head, I think there's maybe about 20, because it's, some universities and some private practices have the ability to do it, but it's not a lot yet. It's just not as widely known at this point. Like in our hospital, we're just starting this. Our hospital is new and we're starting this program, and we are getting ready to kind of travel around the state and talk to the different hospitals in the area, both general practices and specialty hospitals, to let them know, we're here, we have this is what we can do for you. So people know they have somewhere to send their patients.
And this required some extensive training on your part, because I remember when you were, prepping for these classes and so forth. And so are there, let's say other veterinarians are interested in this type of therapy. Can they get educated, certified, or in RRT or renal replacement therapy?
Yeah, there's a lot of ways to do it. So I am still in training through the University of California, Davis, through their veterinary college. They have the dialysis academy. That's where I'm getting my training. You can do fellowships at some universities. When I was in North Carolina at NC State, we had a dialysis fellowship. And then sometimes people are trained within the hospital where they work. Like at our hospital, we will train some of our ER doctors to do it, because the actual act of doing it, of sort of running the machine and know how it works and things, we can teach somebody to do that. And then, then we have people like me and our criticalists who have really in-depth training on it so that we can help oversee them. And so there's a lot of different levels that people can do it.
Yeah, you mentioned, the ER docs, and I was thinking about this when you were talking about traveling around the state, and, earlier when you were talking about conditions that it would benefit, there does seem to be definitely an urgency around, the effectiveness for a given condition. So if they've ingested, a high level of a drug or, a poison or something like that, I would think you wouldn't have a lot of time.
Yeah, it depends on what they got into, and how much time we have. And sometimes the way that we try to look at it is, ideally we see them as soon as possible with a toxicity, say, to be able to get that product out. But a lot of times all is not lost if we don't see them immediately, because we feel like we can at least lessen the impact. And so we can take some of it out. So they may just suffer a little bit, like if it's something that's toxic to the kidneys. Well, we didn't get it all out, and the kidney might take a little bit of a hit, but it'll probably be okay in the end. So we try to talk to them through that. There are certainly times when we're like, no, by the time you get here, it's not going to help. But that's mostly just toxicities. For all the other therapies, it's not necessarily a time-dependent thing. They'll definitely do better the sooner we get them going in almost any of these situations. But all is not lost if somebody has been struggling with a patient in renal failure for a long time, and then they hear about us and they want to send the patient here. We're like, yeah, we can certainly still treat them. They've just been sicker than they needed to be maybe for a while.
Sure. And like you said, with cancer, and then another one of the conditions that I read in doing some research for our chat was about infections such as leptospirosis.
Yeah. So what we treat a couple things with lepto. With that, we treat the renal failure aspect of it, and then a lot of the inflammatory aspect of it as well. And so we can treat a couple things with it, but mostly it's used for the renal failure aspect in the leptospirosis patients.
I feel like, and I could be wrong about this, but I know you and I were talking about this the other day about the resilience of some of the internal organs. And I feel like the kidneys are a little bit more resilient than some of the other internal organs. So in my opinion, I think like the pancreas doesn't really seem like a pretty resilient organ. But the kidney seems like it might be like it could bounce back from acute toxicities and failure and poisoning and things like that. Do you think that they're more resilient of an organ than maybe some of the other internal organs?
Yeah, the kidneys are pretty resilient. And the thing that is important with the kidneys is where were they injured? And so when we look at the kidney microscopically and we get right down to the major part of the kidney that functions, there's the basement membrane in the kidney. And so if that gets damaged, that can be really hard for the kidney to come back from that. And then it would depend on how much of the basement membrane got injured. But a lot of times the basement membrane is intact and just other parts have been injured, and you just got to give it a chance to regenerate. But yeah, the kidney's pretty resilient and it'll do a lot to fix itself.
That reminds me of my friend Denise, a little off topic, but she has had a history of kidney cancer, and she only has one very small part of one kidney left, but she does not require dialysis yet at this time.
When we talk about it, you have to lose like 75% of the function of the kidneys in order for them to not work. And you have two kidneys. And so like you can have like one kidney that doesn't do anything and you don't even know it. You just find out incidentally that, oh, that kidney's not been doing anything my entire life.
The other kidney's doing all the work.
And that's what I'm saying. Like she doesn't have one kidney at all.
Yeah.
And then just a small part of her second kidney, her remaining kidney.
Yeah.
So that just speaks to what you're saying in terms of how, if you can salvage, save, improve the function of any kidney that's there, it seems like it can still do its job very well.
Yeah, exactly.
And it seems like a more efficient treatment than maybe your typical like peritoneal dialysis or hemodialysis. Like, is its success rate better than your typical intravenous fluid therapy?
Well, so fluid therapy, so we're talking about a few different things there. So it's the same as hemodialysis. And it's actually like peritoneal dialysis is the same idea, except the dialysis catheter is just into your abdomen instead of in a vessel. And they do peritoneal dialysis. It still has the properties and the way that it works is still exactly the same. But they do it a lot in people because it's useful for people who have chronic kidney disease and because they can have it at home and things. It doesn't work as well in veterinary medicine. It's just harder to do it in our patients. They're not as cooperative as people.
Yeah, I can imagine.
But when we're doing that, we're actually taking over the function of the kidney and doing the job for the kidney completely. When, say, you take your dog or cat to the hospital and they say, oh, they have, their kidneys, they have kidney disease, we're going to put them on fluids. All that IV fluids are really doing is helping maintain your hydration status, make sure your kidneys are well enough perfused. And the truth is that we do a lot of damage with IV fluids. And we're learning more and more about that. And in human medicine, we see it, and we definitely see it in veterinary medicine, where we give too much fluid, and then we're actually causing damage to the kidneys by doing that.
Oh, no.
Yeah. And
I
so,
didn't know that.
Yeah, we see a lot of that in our, like when we get patients that come to us for kidney failure that have been treated somewhere else, one of the things is they're usually overhydrated, which means now they've been given too much fluid. And part of our therapy is we're taking some of that extra fluid off their body as well.
And that's part of the renal replacement therapy, that this fluid overload is treating it.
Yep. Because almost every single patient has been fluid overloaded if somebody's been trying to treat them. So for us, if somebody calls us and they say, well, we have this dog, it's in renal failure, and they tell us about it. It's like, well, it doesn't need dialysis right now, but why don't you send it to us so that we have it in the hospital? We can try to make sure it doesn't get fluid overloaded. And if it ends up needing dialysis, it's already with us to do it.
So we've talked about the conditions that renal replacement therapy treats, and we've talked about the species that it can treat. Can you discuss a little bit more about what makes an ideal or good candidate? In other words, are there age restrictions? Are there comorbidities or other illnesses that would disqualify a pet from receiving this kind of therapy? We've already touched on, I guess, kind of the size restrictions, because you said like you could do it in a horse, but you're limited a little bit by the size of the machines and so forth. Can you expound on that?
So yeah, so just in general, like what makes us happy? Like we're like, yay, if we get a patient is like a Labrador,
Yes.
They're a big dog, they have big veins, we can put these giant catheters in. They're super easy and that makes us happy. But yeah, so one of the things that overall that really goes into our decisions in almost anything we do in veterinary medicine is, what is in the best interest of the patient. And so one of the things we always consider is just because we can, should we? And we discuss this a lot in the academy about patients, and debate, is this a reasonable patient to even treat? And so we think about that a lot. And so also something like an old pet, well, age is not a disease. And just because somebody's cat is 15 years old and it's got kidney disease, that if we think if we did dialysis, we could make a meaningful difference and we have a reasonable expectation that this pet could benefit from this care, we would do it. But if we feel like we're just not going to make it better, like it's the patient that has chronic kidney disease, it's the end of its kidney disease, like it's at the end stage, we're not going to make these kidneys any better. We're just going to put this animal through a lot of treatments for what, So those are patients we wouldn't treat. With comorbidities, I don't know that I would, if I had a patient, somebody came in and they said, well, this patient has heart disease and it had lymphoma and now it got a urinary tract infection that spread to its kidneys and now it has an acute kidney injury. I would still treat that patient if I thought it had a reasonable expectation of getting better. So that wouldn't necessarily come up that much. I think the biggest thing that could get in our way is if we have a patient that had something where it couldn't clot well and make clots. It would make it very hard for us to treat it because we can't put a big giant catheter in a patient that can't clot because it would bleed out from the catheter.
So you're thinking about patients that might have von Willebrand's, things like that.
Yeah, well, von Willebrand's, actually, we could treat them ahead of time so they could make a clot, put the catheter in. But if part of their disease was they couldn't clot, like liver failure, and they can't clot. If we can try to give them plasma and try to help that, but if it's like they just can't make clots, we can't possibly put that catheter in. So something like that would stop us from being able to treat them.
That makes me think of rat poisoning as well, because isn't the mechanism by which that works kind of causing the animal to bleed out internally and not clot?
Yeah, rat poisoning, though, is not something we would use one of these therapies for because just giving those patients like plasma would fix them. And so, so there's also like with anything, like I had mentioned, ibuprofen is a big toxin that we see. Just ingesting ibuprofen wouldn't get you plasma replacement therapy. You'd have to ingest enough that we would be worried that it would cause kidney damage. Because sometimes if they ingested a smaller amount, it might make them nauseous or give them some gastrointestinal signs, but their kidneys would be fine. And so it has to be things that are going to be life-threatening as far as toxicities go.
So again, rat poisoning would not be one of the indicators, even though this treatment is indicated for some types of poisonings. And you've mentioned ibuprofen quite a bit. And isn't acetaminophen highly toxic in cats? And would that be an indicator for this type of therapy?
If it was a high enough dose. Yep.
Sure.
And then and also the other things that come into play with things like toxicities is we look at what's called the volume of distribution. And what that means is when we're treating a patient with renal replacement therapy, in the body, there's these different compartments. So there's the intravascular compartment, that's the vessels. There's the interstitial compartment, and that's the tissues outside of the vessels. And then there's the intracellular compartment, and that's all the fluid that's inside your cells. And when we're treating you with renal replacement therapy, we can only treat the intravascular compartment. So if there's a toxicity, say, that's been ingested, that very quickly spreads to all of those other compartments, it can be very difficult for us to treat it. And so we may not be as effective as we would like to be, or they may need multiple treatments because as we take it out of the intravascular compartment, it might shift like from a different space back into the intravascular, and then we get more. But that can come into play, like, do we have a reasonable expectation that we can remove this, or is it so diffusely spread in the body, we're not going to help by trying to do it.
So just one more question on, things that would be indicated or not. You mentioned like, a lab is an ideal, patient for many reasons, but back to the size thing, I mentioned the horse being too big. Is there an animal that would be too small? I mean, I know you use this on cats frequently, but like birds or these little teacup chihuahuas and Yorkies and, they're only like 2 or 3 pounds.
Yeah, no, because one of the things that we can do with the really small ones, like, you start to get into those little tiny, because sometimes you get these really little tiny cats or these little teacup chihuahuas or the little Yorkies that weigh like 1 kilogram. The thing that we can do is what we do is called prime with blood. And what that means is as we're getting ready to do the treatment, as we're setting up the system, we run usually like saline or something. There's fluid we run through the filters and all the tubing, so that's not full of air, right? And then we start to hook the patient up and take the blood and run it through. Well, if they're really, really tiny, one of the things we do is we use blood. So either, if it's a cat blood, or if it's a dog blood. And instead of using something like saline to prime the whole system, we actually use blood to prime it. And so we're just giving them blood back, but it's just not their blood. So we can make adjustments for the really tiny ones. But the thing that I think would make it difficult is, I heard Kathy kind of pipe in with a bird, is we'd have to be able to get the access. And so with a big bird, that would be easier, but something like a little parakeet or something, it'd probably be pretty hard to get good enough vascular access that we could draw that much blood out, because it's not the same as just taking a blood test. You stick a needle in, like we have a giant catheter that we are just constantly sucking blood out of their body and putting it back in on the other side. And so we have to be able to get a big enough catheter in there that we can do that. So sometimes they might just be too tiny. So as you were talking, Chris, I was in my head picturing like a guinea pig or like a hamster,
rabbit.
Exactly.
People will bring those in, but I don't know that we could get good enough vascular access to treat it. Would definitely be. And then also, I don't know how we would do blood replacement for something like that.
So this is where sort of like blood donation kind of comes in, right? With some of our animals.
Yeah.
And the importance of that.
Especially in cats, dogs are really helpful. A lot of people are, have their dogs that work as blood donors in different hospitals, but it's hard to get cat blood donors.
That's even important for people to know that this exists, that they can have their pets be donors. And me, layperson, in a way, like I didn't even know that, like, cat blood is specific to cats and dog blood is specific to dogs and that sort of thing. I mean, now that I think about it, I guess that makes sense, but you make a good point.
And we talked a lot there about like the sort of maybe the potential contraindications for using renal replacement therapy, but are there complications that can occur from this type of therapy with our pets?
There's a lot of complications that can occur. Most of them are involved, with the big dialysis catheters. And so, because they're probably our biggest headache, they can get infected, but they can form clots, so the catheter doesn't work as well. Sometimes they get dislodged, they come out. And those are catheters that are designed, especially for patients with kidney disease, to be in there for months long. Like, we don't want to replace them. There's not a lot of other places you can put them. But then also when we are treating them, what we have to do is work. So I had made the comment about, it would be difficult to put one of these catheters in a patient who can't make clots. But when we are treating them and we're pulling the blood out and we're running it through the machine, one of the biggest complications can be the blood clotting in the unit. Your body has natural mechanisms in place that manage to maintain a balance between you making clots when you need them and not making them when you don't need them. But when we take that blood out of the body, it's going to want to clot. So we have to give them medication. Usually we use heparin to help them not make clots so that we can run it through the machine and the machine won't get clogged with a lot of clots. But that makes them a greater risk for bleeding complications because they're at a risk for that for about 12 hours after the treatment. So that's always a risk is hemorrhage. Then we can also have things like as we're changing things in the body. So say we're treating a dog or a cat with kidney disease and their kidney values are really high. Those values, those products have quite a bit to do with the osmolarity and the fluid balance in the body. And so the BUN or the urea, if we take that out of the blood too quickly, it causes all these fluid shifts in the body and can cause actually swelling in the brain and can cause death if we don't do that carefully. Sometimes if we get too aggressive in how much blood we're taking out, or if we're trying to get fluid off because the patient has been fluid overloaded and we take too much out of the vessels, we can cause their blood pressure to drop. And so those are the major complications that we can see with these guys.
Hence the extensive training, right?
Right. Yeah. You really got to know what you're doing because you're really playing around with the body's balance of a lot of things, all of the electrolytes and everything, because we're also a lot of the other electrolytes we're not playing around with too much, but sometimes you need to. So sometimes the sodium, we might want to adjust that. And if it's too high in a patient, we want to kind of get it down. Or if there's so much you can play with. Like, so if we feel like we want to get more fluid to go into the vessels of the patient, we can make their sodium higher by the way we set the dialysate and stuff. And that's fine. And then we can adjust that. But then that'll make that patient more thirsty and it can make them uncomfortable and it can do all these things. So there's all this like modeling of electrolytes that you can do. But you have to keep in mind what you're doing. It's not just that number. It's like, whoa, what am I doing to this patient?
So let's shift to a more positive tone. What are the success rates? And like, are these treatments typically one and done or repeated? And if so, how often? And then ultimately, how do we know when we're done treating with RRT?
So it depends on what we're treating. And so a lot of toxicities are often one and done. Some toxicities need more than one treatment. And those are drugs that have a large volume of distribution. And so we treat them. And then it can be difficult to tell. But if it's, say, a toxicity like a patient got into a whole bunch of phenobarbital, well, that's going to make them, dull and sleepy. And, they can end up needing mechanical ventilation if we don't treat them. And so you bring them in and you treat them and you pull off the phenobarbital and then they're bright and they walk out of the dialysis room looking great. Well, if they ingested enough and the drug was distributed to other body compartments, the next day they might start to look dull again because it's shifted back into the bloodstream, and then you got to treat them again. Mm-hmm. So with some toxicities, it can be a little hard to know if you're done. We're still working on really figuring out, how much you need. And it's hard to get, the ideal thing is, well, then you just get a blood value and measure it. Well, there's just not a lot of places that'll do that for you or do it quickly. But usually toxicities can be one or two and done. Immune-mediated diseases, at a minimum, will get 3 treatments. And they're usually every other day. So like a Monday, Wednesday, Friday sort of thing. And then we watch and see how the patient is doing. Some patients need more than that, but a lot of times 3 will do it for them, and then that's bought them time for their drugs to work. And then,
can you give some examples of what immune-mediated diseases might be that people may not realize?
Yeah, so I think for veterinary medicine, the big ones that we see that we treat is immune-mediated hemolytic anemia. And what that means is that the immune system is destroying red blood cells. It's a very aggressive disease. It can be very hard to treat. Its prognosis is like 50-50 at best with patients, and they get really, really sick. They're very expensive to treat because they end up needing a lot of blood transfusions. And so when we treat them with plasma exchange, and we are removing the immune mediators so they'll stop destroying their red blood cells, and then give their drugs a chance to work that will work on suppressing their immune system. And so those patients, if we were going to treat a pet for that, we set the client up that you're going to get at least 3 treatments. And then what we're looking for in the patient is that they've stopped destroying their red blood cells. And some patients can be really resistant to treatment. And after 3 treatments, we're still seeing they're destroying all their red blood cells. So we'll do more.
I had a little touch with that in in my agility group, the instructor breeds border collies, and she homed one with a dear, friend who is an excellent agility competitor, and her female puppy got that disease. And they set up a GoFundMe and all of that because, like you said, the cost to treat it and so forth. And I'm happy to report that this puppy pulled through. And she is actively practicing and competing now. So.
Oh, that's good. I can tell you that is a disease sometimes that it's one of my least favorite diseases to treat. I hate it less now that we can do TPE, which is plasma exchange, for these patients, because they will just sit in the hospital and they're so sick and they need blood transfusion after blood transfusion, and we just can't get anywhere. And it's really difficult. So it's much better to treat them.
And myasthenia gravis is another immune-mediated disease that can be treated with this, is correct?
Yeah. Myasthenia gravis is, I think, one of the diseases also that makes me very happy to have plasma exchange to be able to treat. So depending on how the disease presents, sometimes it's kind of chronic and it's still a terrible disease, but it's not as bad. But patients will get it acutely, and they just come in and acutely they can't walk around. And one of the biggest things is they can't swallow well. And so they can aspirate and they get pneumonia, and all of this terrible stuff happens, and they're just in terrible shape. And it's really hard to treat them because they can't swallow well, and they're just in really bad shape. But you treat them with TPE, and again, what we're doing is we're taking away those immune mediators, waiting for their drugs to work, but the patient gets so much better. And they're just like, boom, and they can go home sooner, and they do great, a lot of them. They're like, these are like any other therapy. Not everybody responds, but, the ones that do, it's really looks great. We had one not too long ago that I just discharged him from the hospital. He had stayed an extra night. And I wouldn't even have known that dog had myasthenia gravis if they didn't tell me that's why he was here. Like, he was this big German Shepherd.
Cool.
I have a friend whose dog was diagnosed with myasthenia gravis, and it's terrifying. Within a 24 to 36 hour time frame, he went from just looking sort of stiff and sore to not being able to ambulate at all. And he's a big guy. He's an English bulldog, and he responded well to treatment, but it was really scary and touch and go there for a while. I haven't seen very many cases of myasthenia, but boy, it moved quickly.
Yeah, it's a terrible disease. And then, Chris, to answer you a little further, patients that have kidney disease, it's a little hard to tell because we just have to see how the kidneys will respond. But they're treated 3 times a week, and just until their kidney values get better. What we expect that we will see, to understand it, is we'll treat them. And we don't, in the beginning, we don't make the kidney values from abnormal to normal. That's too rapid of a change, but we make it better. but they'll often rebound. And so like they'll maybe get treated on a Monday and the values look better. But by the time they come back on Wednesday, they're up higher than they were when they left on Monday. And so if you look at the graph of how their values are changing, it's not just a steady drop. It's sort of, like they go up, they go down, they go down, they go up a little bit more, but not as high as they started. And they just kind of go up and down, this sort of waxing and waning thing in a steady decline until they may not completely normalize, but at least the patient is feeling well and is able to maintain without us treating them. And that can be, weeks to months, depending on the disease.
Is the treatment for kidney disease tapered during that time? You said it's 3 times a week. And then as the values improve, does it diminish in terms of frequency?
Not usually.
Okay.
We usually will do it. They usually require it 3 times a week. On occasion, you might have something that you'll back off to 2 times a week, but not very commonly.
What's the cost?
It can be costly. And the thing to keep in mind is a lot of times when we look at this and we look at the cost, if we had to treat them more conventionally, it would actually be more. But for a patient who comes into our hospital for a toxicity and we expect it'll be a one-time treatment, it's about $3,000 to $4,000 because that includes placing the dialysis catheter, and those catheters are expensive. Mm-hmm. And then if it was going to get more treatments, it's about $2,000 each treatment. If we had a patient who comes in and is in kidney failure and is going to need to be in our hospital for dialysis for kidney failure, those are about $10,000 to $15,000 for the first week in the hospital.
So, Dr. Keenan, what is the cost of the machine? I'm just curious what investment the hospital had to make.
So it depends on the machine. So there's different types. We currently have continuous renal replacement therapy. And what that is that works slower. And so it's actually designed to be done when they say continuous, they mean continuous. Like in human medicine, if you have a patient who's maybe in the hospital, you would have that machine by your bedside working constantly. In veterinary medicine, we use it more as an interrupted treatment. So you're not on it for 24 hours. But all of those pieces of equipment, depending on what kind you have, are like $200,000 to $500,000.
Wow. You talked about the length of treatment, but what would you say an average time that pet is there, again, for our owners to kind of get an idea of the length of time it takes to do a single treatment?
Yeah. So again, it depends. So if it's a toxicity that's going to be a one and done, we'd usually bring them in and send them home the next day.
How long are they actually on the machine though?
Oh, on the machine. Yeah, it depends on which machine we use, but usually they're on the machine at least a minimum of 3 to 4 hours.
Yeah, that's what I was thinking. It would be a matter of hours. It's not like 15 minutes or 24 hours, but yeah.
Okay. Yeah, because when we talk about treating them and we're figuring out how we're going to treat it and what we're doing, we talk about running blood volumes, so like I said, like the idea of it is the blood is treated outside of the body. And we don't just do like one blood volume. Depending on what you're treating, you might say 1.5 blood volumes with some toxicities, we're like 20 blood volumes. So they're on that machine while we run their entire blood volume through 20 times.
Gotcha.
We covered so much today and we learned so much. Maybe we can, as we're kind of closing up, maybe Dr. Keenan can share a case with us. A success that she's experienced.
I would love that.
I think one of the ones that one of the cases that really got me interested in this was a dog when I was at the vet school in North Carolina. We had a dog come in who had gotten into his own phenobarbital, and he had done it before as well. And he got an overdose of phenobarbital. And when he came in, he was barely able to walk into the building. I was thinking we were going to need to intubate him because he was getting where he wasn't breathing for himself. Either our dialysis, the head of our dialysis department heard about the dog and was like reaching out to me immediately. Like the dog walked in the door and this guy was calling me, Dr. Bagani, and he's like, "You got to get that patient in. We have to dialyze that patient." And it took a little bit for me to get the clients on board because they thought that we were just going to put him on fluids and he was going to be on mechanical ventilation. And we could have done that. He would have been on that for probably several days on a ventilator. But I talked them, I finally got them to listen to me and hear me. And everybody ran in. We got him hooked up. We never even had to intubate him and breathe for him. Got him into dialysis. And halfway through the treatment, we had to get sedation for him because he was trying to get off the table. And he went home the next day.
Wow.
And it was one of these dogs that, like the owner said, he's gotten into it before. And I had it up in a cabinet and he got up on the counter and said, why?
Why?
Yeah. Of all the things he could get in the cabinets.
Yeah. Like he just wanted his phenobarb. It was crazy.
Well, this has just been so interesting for me because as I alluded to earlier, I'm but a lowly physical therapist, and, Kathy as a long time, very experienced veterinary technician, and Dr. Keenan with all your credentials as a veterinarian and your special training, loved geeking out with you guys on this treatment. And I can see, Dr. Keenan, why you would be so excited about the prospects and doing something so novel, really, in veterinary medicine, but needed, So thank you for joining us today and lending your time and expertise.
Thank you for having me. I love talking about this and helping people understand all the stuff that we can do. When clients come in and this is introduced to them sometimes and they're like, what? And then, like the ER doctors will talk to them and then they'll say, can you go talk to them? And then I'll go talk to the clients and they're just like, wow.
Yeah. Yeah. I'm like, wow. Yeah.
And Kathy and I, that's part of our mission, Dr. Keenan, is to expose a larger audience to all of these different things, to ultimately help their pets live better lives and survive things that maybe they normally wouldn't. Yeah. So, just having this exposure and, hearing these terms and so forth, maybe, people will do their research, find out, where the closest center is to them that has this type of therapy and so forth. So it's just a win-win, I think, all around.
Yes.
Yeah, I think, and that's what I think is great. Like you said, like just getting that knowledge out to people, like all of the stuff that can be done for your pets.
It's amazing. I think just about anything you can get for yourself, you can get for your pet.
Like you said, it's been around for a while, but it needs to grow. And I think it is very slowly, and we'll be able to do more amazing things as a community.
Right. So Dr. Keenan, as we're wrapping up, can you let the audience know where they can find you if they want more information on renal replacement therapy?
Yeah, you can email me at kathy.keenan@nva.com.
And that's Kathy with a K, right? Kathy.Keenan with a K. Okay. Right.
Yeah. The practice I work at is Pacific Northwest Pet ER and Specialty Center, and it's in Vancouver, Washington, which is just over the line from Portland.
Thank you, doctor. And we'll make sure we put that in our show notes for our listeners. Thank you, Dr. Keenan. Thank you so much.
Okay. All right. Thanks, guys.
I'm going to take good care. Bye-bye.
Thank you for joining us. We hope you enjoyed our show.
Follow us on social media at Petability Podcast.
And please check out our affiliates and sponsors.
Simply go to the show notes for information and links.
Thank you, and tune in next time.